Okay, I give you a scenario, Dr. Jabran. There is a patient, 70 years old male, who presented to you with pain abdomen along with the PR bleeding, parectal bleeding. So you're using your communication skills, you have to complete your history in the next 6 minutes.
Okay. Hello, my name is Dr. Jibran and I'm one of the surgical doctors working over here. So, can you please tell me what brings you here today?
Yes, doctor, I have pain here in my tummy for the last about 6 months. Um, but more distressing for me is this bleeding from my back passage. It's really haunting me.
Okay, and can you please tell me more about this bleeding? When did it start?
Yes, doctor, it started about 2 months back, and it's increasing every day.
Is it painful while you defecate, while you open your bowels?
No, no.
Okay, and have you lost any weight in these 5 months while you have this bleeding?
Yes, doctor, I have lost about 10 kg of weight in these 2 months.
Okay. And I mean, while opening your bowels, do you have pain as well along with this bleeding?
No.
Okay, so it's a painless bleeding. And can you please tell me the color of this blood that you are having? Is it a bright red blood? Is it maroonish color?
Yes, doctor, it is bright red.
Okay, it is bright red color. And does it contain any mucus?
Yes, doctor. Sometimes it contains mucus, a slime.
Okay. And how are your bowel habits? I mean, how often do you open your bowels?
Yes, doctor. Eyes. Usually, sometime I go for not even for 1 week, and sometime I have to go 2 to 3 times a day.
Okay. And does this opening of the bowels, and you are saying that you have this bleeding as well. Is it like diarrheal in nature? I mean, sometimes you're saying that is it intermittent? Like sometimes you have to pass, open your bowels in 3 times a day, and sometimes once a week only.
Y-
I mean, how is your stool? I mean, is it hard or is it of normal consistency?
Yes, doctor. It is sometime normal and sometime it is hard.
Okay. And have you used any stool softeners in these past 5 months?
Yes, sometime I have to use when I don't pass it for 1 week even.
Okay. And do you have any family history of cancer or any family history of anything?
Yes, doctor. My father had cancer of the large bowel.
Okay. All right. And do you have any other past medical, any other problems apart from this one? I mean, do you have any asthma? Do you have any diabetes, any hypertension, any heart problems, anything?
Uh, mm, no,
Okay. Do you take any regular medications for anything?
no,
Do you use any blood thinners?
no.
Okay. Um, all right. Um, okay. Now, as far as apart from taking your history, I think I have asked everything that I needed to ask, and now I will just move on to some investigations. Then, I mean, no, no, I mean, I think I have asked everything in the history, or do I need to ask anything else as well? doctor.
Okay.
I'm not too sure.
So your history is completed, right?
Yeah, I mean, apart from my side, I think I have asked everything, most of the things, or everything maybe.
Okay. Now present your case.
Okay, so this 50-year-old man, 50-year-old male presented to me with a 5 months history of painless bleeding from painless bleeding. The bleeding is painless, and the patient also complained of weight loss of approximately 10 kgs in these 5 months. The patient also reported that there is no pain while defecating, and also complained of um, intermittent diarrhea and intermittent constipation as well. Sometimes open his bowels in 7 days, and sometimes in 3 times a day. There is a past medical, there is a family history of cancer of the large bowel in the family as well. However, the patient has got no other past medical histories, and the patient is not on any medications for now. Just the stool softness that the patient is saying that he has taken as over-the-counter medications, uh, and Um, based on this, based on this, my differential diagnosis would include cancer of the colon, cancer of the large bowel, or irritable bowel syndrome. Or I would also check for ulcerative colitis and Crohn's disease as well.
Okay. What?
And
Which investigations you will do? What? Sorry.
okay,
What is what? How will you manage this case?
So, I mean, I would like to first do some investigations on the patient. I would like to rule out, I would like to do a full blood count. Some general investigations include full blood count and urine electrolytes. And I would do some specific investigations as well, which includes the cancer markers to rule out the cancer in the cancer of the colon. Also, I would like to do CT scan as well. I mean, if if the cancer markers are raised in the patient, then I would like to do CT scan to get some insight on the staging, or
Which
if
one
there is any.
investigation? Which one investigation you will do for this patient?
Um, I'm sorry, I don't remember. It may be carcinoma embryonic antigen (CEA).
Okay.
Is
How will
I'm not too sure
how will
about it.
you,
I mean,
how will you treat this case?
So if it is a cancer colon and if it is in the initial staging, I would do surgery on the patient, and after that, after the surgery, I would give the patient radiotherapy or chemotherapy for complete remission.
Okay.
If the cancer is in advanced stages, then the patient might benefit from radiotherapy, and if there is metastasis and if the cancer has metastasized, then the patient would be for palliative care, as a surgery won't be a viable option at that time.
Okay. Great. So anything? Great. Thank you so much, Dr. Gibran. So nice of you. So anyone, if want to add something, so please raise your hand. Yes, Dr. Sonia.
Hello, sir. Can you hear me?
Yes, yes, sure.
I think I would like to order a colonoscopy.
Colonoscopy. Great. Great. Excellent.
Yeah,
Anything else you
yeah,
want to know?
yeah. Also, an MRI as well.
Ah, okay.
Uh, yeah.
Great. Dr. Wahid, yes. Dr. Wahid. Dr. Wahid, you are, yes,
Okay, can you hear me?
yes, yes. No.
My main diagnosis based on the case given in history will be Crohn's disease or ulcerative colitis, apart
Great.
from colorectal carcinoma.
Okay. So what will be
And
your top diagnosis? First, what will be your first diagnosis and second diagnosis?
Um, my first diagnosis. Have what was the age of the patient?
70 years.
70. Then of course it's colorectal carcinoma because he had a strong family history, and at this
Okay.
age, colorectal carcinoma should be
Okay.
our first
Great.
diagnosis.
Great. And second diagnosis will be
Uh,
inflammatory.
Inflammatory bowel disease.
Inflammatory.
It may be Crohn's disease or ulcerative colitis.
Great. Great.
Mm,
Okay.
thank you.
Okay. Great. And next. Okay. Anyone else want to add something? In history, asking the questions or in the differential diagnosis? Yes, Dr. Aksam.
Before I'd like to move on for the treatment, I'd first like to stage the disease, whether the disease is resectable or not. And for that, I would order a CT chest, abdomen, pelvis, along with as Dr. Sonia mentioned, a colonoscopy and an MRI of the abdomen and pelvis. And if the disease is resectable and it has not spread in the liver and there are no liver mets,
Okay.
then the
You want
treatment would be
to stage
planned
the,
according to that.
you want to stage the disease first before the treatment, right?
Yeah, exactly.
Great. Yes, Dr. Vakas. Dr. Vakas, you are muted.
Hello, can you
Yes,
hear me?
yes,
Sorry, sir, I am traveling. That's why I couldn't perform right now. So, sir, in the history part, the initially you should confirm the patient age and name
yes,
before proceeding,
yes,
and then you should be empathetic. Like if patient mentioned that he's having bleeding or hemorrhage from the upper rectum, so you should be like, it is so sad to hear about that. You have to be more empathic about for the patient. Other
excellent.
than that, sir, he didn't ask about the pain. You have to ask about the pain also, where it is
Explore,
located,
explore the pain.
side duration.
Right.
Yeah, you have to explore the pain. With that, he has covered, I think, almost all the things in the bleeding PR. But with that, he must also ask about the addiction history and personal history before that, taking permission to the patient that can he ask about some personal questions.
Yes, yes, excellent.
After that, sir, then initially the blood investigations is required to see CBC, SR, CRP, and see the whether the patient is anemic, any increased leukocyte count, infection
Excellent.
to rule out infection.
Mhm. Good.
Then for the specific diagnosis, we should do the colonoscopy, and if there is a mass, we take the biopsy of it, and then we
Good.
stage the disease. Then for the metastatic workup, we should proceed like to see the any mets in the chest by CT scan, abdominal ultrasound, or abdominal CT and bone scan if there is any metastasis of that. According to the patient and the history, it looks more, it has more weightage toward the colorectal carcinoma. With that, tumor marker may also be undertaken, like CEA levels also be important here. Thank you.
Okay, great. Thank you so much, Dr. Vakas. This was complete analysis. Excellent. So, anyone else want to add anything? Okay, now take your pencils and some page. I am going to dictate very important things which are very handy, necessary for the exam purpose. And I hope that this will work. First of all, what you have to do while you taking the history, how this station will come in your exam. I hope all of you know. If doesn't know, then I'm going to tell you. So it will be a 9-minute uh, case, and for 1 minute outside the cube, there will be a question printed outside the cube, and you have to read the question very, very carefully. For the next 1 minute, you have to ponder upon that what is going on with the patient and what does the examiner want from you, right? So this 1 minute is very, very important. First thing, what happened in the in the nearby exam, one of the candidate went into the station, history station, and he started performing examination. It was a history station, and he started performing examination. So be very careful. Either is it a history station or it is an examination station. So this 1 minute is very, very important. Second thing, so you enter the exam. Now, obviously, you have to introduce yourself to the patient and you have to introduce yourself to the examiner as well. So first introduction with the examiner and then with the patient. So you will introduce to the examiner like, um, my name is Gibran Ilyas. My candidate number is 544678. That's all. And then they will just ask you, okay, proceed. So next is introduction with the patient. So, and you are sitting, you are setting, all these are very important. And the examiner will start marking from the point where you start your introduction with the patient. Remember, your marking is not started when you take the history. Your marking is started when you start your introduction. You from your sitting, we call it as setting. From your setting, and then introduction, and then taking history. So how should be your setting? First point, how should be setting. Uh, Dr. Oluwisun Femi, how should be your setting for the exam, for the history taking? Dr. Varda, how should be your setting? Do you know? If anyone knows that, how should be your setting for the exam? Yes, Dr. Shafiq. Yes, please. Dr. Shafiq. Dr. Shafiq, you are muted.
Sorry, I'm sorry. The position of the chair from the patient should be at 90-degree, and you should be lean slightly forward, and your hands are not crossed, or I believe.
Right. So number one, you should be facing the examiner, or for facing the patient. Sorry, you should must be facing the facing the patient. Number one, you must be facing the patient. They have deliberately put the chair in some other direction, but you have to take the chair and just put the chair in front of the patient. Number one. Number two, you should be sitting, not leaning backward and taking the support of the chair. You should be sitting at the edge of the chair, leaning forward, hands in front of you, and legs must not be crossed. So this is your sitting. We call it as setting. So this must be your setting. So I repeat it. You can write down. In front of the patient, facing towards the patient, sitting at the edge of the chair, hands in front of you, leaning slightly forward, and legs must not be crossed. Number one. Number two, they will provide you a pencil and a paper. So you will keep that paper on your leg, and you are allowed to write, to take necessary notes if you want, but you won't see at the paper while taking the notes. All the time Your eyes must be in contact with the patient and not with the at the paper. So these are two very, very important points. Remember, there are two examiners in the history taking station. There are two examiners. We call one examiner as the layman examiner and the other one as the knowledge part, knowledge examiner or the clinical examiner. The layman examiner observes your all activities. You are sitting, you are leaning forward, your legs, your motions, your body language, all these things. And that is marked. So this is very, very important. Now you start with your introduction. So introduction is contains not one part, but two parts. In number one, introducing yourself and then taking introduction from the patient. So as Dr. Wakas said, that you will introduce yourself. Hello. So it's not only hello, it is hello. After that, either is good morning, good evening, whatever it is. Hello, good morning. If it is morning, if it is evening, good evening. And one very, very important point again, please read carefully the scenario. If you are appearing in the exam in the morning, but at the scenario at your paper, it's written that you, patient presented to you, for example, 9 p.m. So you will not say that good morning. You will say good evening. They do it deliberately. So what happened um, in one of the exam that the candidate went in, he said that hello, good morning, because the exam was in the morning, and the patient said, doctor, you are telling me good morning. Have not you read the scenario that it is 9 p.m.? It was called from the patient. So what you will do at that time? Obviously, you will be confused and your whole station will be ruined. So this is what you have to do. That is why I say that 1 minute is the key. Read the scenario very, very carefully. And in the next 3 months, we are going to make you practice the scenario, reading the scenario that for that 1 minute very carefully. Number one. Okay. So hello, it is not only hello, it is hello, good morning, good evening, whatever the time is. Hello, good morning. Then introduce yourself. Instead of saying, my name is Wahid, my name is Aksam, say, I am, because it is more professional that you're a doctor and not candidate and not the patient. Hello, good evening. I am Dr. Wahid Ahmed, one of the surgical exam candidate. Okay, this is your introduction. In most of the history stations, your introduction will be like that. In very few, like if the patient is already admitted in the ward, now again take your notes. If the patient is already admitted in the ward, what happens will happen now. Your introduction will be changed. Hello, good evening. I am Dr. Aksam, part of the surgical team taking care of you. Why? Because the patient is already admitted and you are treating the patient. In some stations, for example, in the depression, in other stations, the patient is already admitted. So what you have to do, you will tell the patient, I am Dr. Wahid Ahmed, part of the surgical team taking care of you. Next, you have to take introduction from the patient. So you have to take, you have to confirm that is it the same patient or not. So there are two, again, if the patient is outpatient department, then you take introduction differently. If the patient is in the ward, it will be different. If the patient is presents to you first time in the OPD, then you will ask the patient, may I confirm your name and age, please? May I confirm your name and age, please? And if the patient is already admitted in the ward, then your introduction will change. What you will say, if I'm not, if I'm not wrong, if I am not wrong, you are Mr. Alex or Mrs. whatever the name is mentioned in the scenario. If I'm not wrong, you are Mr. Alex and your date of birth is this or age is this. So this will be your introduction. Okay. So up to here, up to introduction, you have gained 3 marks. Remember, this 20 station mark is just like getting and gaining 20 coins. You have to pick each and every coin, and every coin is of single rupee, right? So it's not that this is direct 20 marks, it is 1 1 1 1. So up to here you have done nothing, but you have gained 3 marks if your setting is right and your introduction is fine. Now you have to ask the patient, okay, when the patient will say to you, for example, patient says that I'm Alex, 70 years. So, so what you will do next? You will not say, okay, how may I help you? No, you will say, nice to meet you. And then you will say, how may I help you? How may I help you? Now I am telling you a very key point. A few days before, one of the Royal College examiner told me that Zulkarnain, if you are Zulkarnain, you would pass the exam if you are excellent. But if you are Thomas, you will pass the exam if you are okay. I hope you got my point. If you are Thomas, you will pass the exam if you are okay. But if you are Muhammad, if you are Zulkarnain, you will pass the exam if you are excellent. Why? It's not that they are differentiating. It is because they know how to communicate with the patient. What we communicate, that is totally different. In our Pakistan, Indian setup, and specifically Arab setup, our communication is totally different. Here, the normal communication, they would never say, "Do uh, uh, open the door. Can you please open the no? Would you mind if you please open the door?" Just like that. They are so soft. So in the exam, what they judge is only your communication skills. 70% your communication skills, and 30% you related to your skill, other skills and knowledge. So next, the patient will say, okay, then now you will say that, okay, nice to meet you, Mr. Alex. How may I help you? When you say, how may I help you? So your help should be like help. It should not be like, okay, how may I help you? This is one thing. One thing. And second thing is, okay, nice to meet you, Mr. Alex. How may I help you? So it is totally different. So your help should be help. It should not be like taunting someone. Okay. Now, how may I help you? Then the patient will say that I have pain in my tummy. I have bleeding from my back passage, I have vomiting, I have pain in my knee joint, I have pain in my back pain. So when now listen very carefully. When the patient says to you that I have pain, I have bleeding, no, it is your time to gain the marks. You will say that, oh, I am really sorry to hear that. For example, if the patient says that I have pain in my tummy, you will say, oh, I'm really sorry to hear that. It must be discomforting for you. Do you need any painkiller right now? These three sentences must be on your tongue. Reflexes. Oh, I'm really sorry to hear you. It must be discomforting for you. Do you need any painkiller? So if the patient says that any pain, then ask the patient painkiller. If the patient says I have back passage, bleeding, say that, oh, I'm really sorry to hear that. It is hurting for you. So do you need, are you comfortable while answering my questions? So that it means that you are taking the consent from the patient, that is it okay for him to proceed or not, and that is very important. Okay, now the patient, and it comes in empathy. If you have not showed empathy, your marks will be 110% detected. Remember, this empathy is key. How you can ignore a patient? Patient is saying, I have pain in tummy, and you are saying, okay, when did it start? Or patient is saying, I have back bleeding from back passage, and you are saying, okay, what was the color? What was the start? No. First, ask the patient that is he comfortable or not. Then move forward. Next, okay, patient says that I have pain. For example, just quoting the example, patient says I have pain in my tummy. Now you will complete your Socrates. That is very important. If for now, after this, uh, when the patient states one complaint, now there will be a general arrangement for all the history taking scenarios. Most of the history taking scenarios. The next, maybe I think there are 10 to 15 points will be same. So first you will complete the Socrates. So if I have to complete my Socrates, Dr. Zishan, I see you. Dr. Zishan, I know you are on Mars, but you can speak if you have good internet. Okay, if I have to complete my Socrates, your Socrates must be completed within 1 to 1.5 minutes. So this is very important because we waste our time. We waste our time in taking the history in unnecessary things. So there are 7 to 8 questions related to Socrates. So let's practice that how you can complete this Socrates in 1.5 minutes. For example, I would say, okay, Mr. Alex, uh, when did it start? Mm-hmm. Okay. It started suddenly or gradually? Where it is? Can you please point for me? Anything increasing or decreasing it? Any other thing associated with that? Is the patient this pain on the same side or it is moving anywhere else in the body? Any fever or vomiting or diarrhea or yellowness of eyes or shortness of breath with that? Mhm. If you have to rate this pain from 1 to 10, 1 being the lowest and 10 being the highest, how would you rate? Mhm. Is it um, uh, disturbing your daily life? Okay. Anything increasing or decreasing your pain? Have you taken any medication for that? So it is completed. My Socrates is completed, and I took not more than 1 minute. What I did, number one, I did not say, number one, I did not say for before every sentence, can you please tell me? This is not important here. You have already spoken it before that. So while you are answering these questions, asking these questions, don't include before every question, can you please tell me? So it will just waste your time. Number one. Number second technique is that I have asked not the complete sentence, only the important phrase where it is moving any elsewhere in the body, anything increasing or decreasing it. So I did not include the whole sentence, just the important phrase. Number three, the relevant things. For example, I did not ask in two sentences anything which increases your pain, no, and then anything decreasing with your pain, no. No, I included in a single tense sentence anything increasing or decreasing your pain. Similarly, for the associated symptoms, I included all the symptoms in the same, anything uh, associated with that, like vomiting, diarrhea, constipation, or shortness of breath, or yellowness of eyes. So I completed all the five things in one sentence. One thing I forgot was character of the pain. So usually, my past experience says the candidate said, "What is the character of your pain?" So patient doesn't know what is character of the pain. You have to tell him that what are those characters you want to ask. So you would say, which character the pain is like. Is it stabbing, colicky, sharp pain, shooting? So you have to mention these 4 to 5 things to the patient, and the patients usually know that what type of pain is it dull pain, burning pain. So 5 6 things you must include. Similarly, for the associated symptoms, some candidates go, what are the other associated symptoms? So patient doesn't know that what are associated with that. You should know and ask the patient what are those associated things you want to ask and you want to explore. So this Socrate, because about 80 to 90% of the patients will present to you in the exam with the pain somewhere. So you must know that Socrate to be completed in 1 and maximum 1.5 minute. So this is very important. So after this Socrate will come differential diagnosis. So your differential diagnosis is very important. And you should know that which differentials are important according to the scenario and according to the Socrates, and which are not those important and can be left as a later on, right? So this is very important. Next, you will ask 4 to 5 differential diagnosis. 4 to 5 differential diagnosis. Sometimes you have to include more than 5 to 6, but most of the time it is up to 6. So important, for example, because today we are discussing the importance of abdominal pain and PR bleeding and all these things, and because this station is very important and being repeated uh, again and again, and patients and candidates can get confused in the exam. So that is why started from it. So, for example, no, there are two scenarios which are very important. One is that patient presents to you with pain abdomen and diarrhea. And the next is patient presents to you with PR bleeding and pain abdomen. So these are two scenarios will be given. Number one is diarrhea and second is PR bleeding. So remember, PR bleeding, PR bleeding is more specific for colorectal carcinoma as compared to inflammatory bowel disease. Diarrhea is more specific for IBD as compared to colorectal carcinoma. It's not my stats. These stats are from the books. So you should know from the scenario again that 1 minute, that what was the complaint there? That was PR bleeding or that was diarrhea? If it is diarrhea, the most probably patient will be having IBD. But if the patient is having PR bleeding, that will be most probably colorectal carcinoma. But in both of these scenarios, you have to include in differentials and exclude both of these. So you will ask the questions specific to colorectal carcinoma as, as well as IBD. For example, what are those specific questions for colorectal carcinoma? Anyone? What are those specific questions for colorectal carcinoma? Yes, Dr. Vikas.
Uh, Age of the patient, weight lost, and
Age of the patient is done. Weight loss, good.
and with that, if the amount of bleeding it's every diarrhea.
Sorry,
I'm saying with every loose motion or with every episode of the defecation, he will have a
every
bleeding PR.
defecation, with every bowel movement, there is PR bleeding. Number two, good. Anything else?
Uh, there may be associated a strong history of family. Family history
Family
will be
is
strong.
excellent. Anything else? Yes.
And
Dr. Mustafa.
smoking, maybe smoking will be the and any risk factor with it.
Yes, good, 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 good. Dr. Mustafa, yes.
Alternating bowel habits.
Excellent. Alternating bowel habits. Good.
Tenesmus.
Tenesmus. You look general surgeon.
No,
Tenesmus.
orthopedic.
You are orthopedic. That is even excellent. So excellent. So remember. Thank you, Dr. Mustafa. Remember, if you have not asked alternating bowel habits and tenesmus, just 1 minute. Give me a second. Hello. Good morning. Good evening. I'm taking class right now. Yes, Dr. Root, yes, I will be available for the session tomorrow. At what time suits you? I will be available in the hospital or at my residence. I will be available for you, and it's okay for me. Okay, sorry. So remember these 5 to 6 things. Number one, age of the patient. That will be a clue. So number one. Number two, patient will be having PR bleeding. That will be a clue in the scenario already. Number 3, weight loss. That may be also in the IBD as well as in the colorectal carcinoma. So it may be common. Number 4, altered bowel habits. Altered bowel habits, alternating bowel habits, these are specific for colorectal carcinoma and not for IBD. If the patient says that I am having alternating bowel habits, how would the patient say? Patient will not say that I'm having alternating bowel habits. You have to explore it. You have to ask. What question you will ask? What about your bowels? Patient will say that it's okay. No, it's not that okay. We'll say, do you have sometime constipation and then diarrhea? Is it like that, or it is continuous with diarrhea or continuous only constipation? So you have to explore it like that. So alternating bowel habits, and then very important and the first sign, I would say, or sometime even the symptom, the patient sometime the patient presents to you only with tenesmus. The patient says that I have only one problem, that I'm not satisfied with my after my defecation. So you have to explore it. It must be included while you are excluding colorectal carcinoma. So what will be your question? Okay, Mr. Alex, are you satisfied when after your defecation? Are you satisfied after your defecation? Because you have to include very short question. Are you satisfied with your defecation or after your defecation? So this will be the question. And then obviously the family history. If the patient is having family history of colorectal carcinoma, then you have to include your top differential as colorectal carcinoma. Now comes towards IBD. In IBD, patient will be having diarrhea. The bleeding in that IBD is not solitary bleeding. It is actually bloody diarrhea, just like bloody civilians. So it is bloody diarrhea. It's not just PR bleeding. So you will ask the patient when exploring the PR bleeding that is it like you having bloody diarrhea, or is it blood comes separately from your stools? So simple. I will include separately the questions you have to ask related to PR bleeding. But this question is just related to rule out uh, bloody diarrhea. Okay? So you will ask this question. In PR bleeding, if the patient is having PR bleeding or bloody diarrhea, don't miss one very important question. Number 1, taking any anticoagulants. Number 1, taking any anticoagulants. Number 2, is the patient having bleeding from any other orifice, like from the urine or from the mouth? So this must be included, this question, in PR bleeding. That is the patient having any bleeding from the mouth or from the urine or from any other body parts. So that just to exclude any blood disorder. And then obviously about traveling history, you have to include about the traveling history, that if the patient is having some that problem. Okay, so differential diagnosis are done, for example, and then obviously you have to exclude one thing is hemorrhoids. For hemorrhoids, you have to ask anything coming out of your back passage, then anal fissure. Oh, for yes, anal fissure. For anal fissure, your question, what will be your question, by the way? Anyone? What will be your question for the
Sir, we
anal
will
fissure?
ask. We will ask the patient if it is painful, and how how means is it starting before when a pain is starting with pain, it is defecation, or bleeding is starting first and then you are doing your defecation.
Okay, good question, but you have to improve this. Good question. Yes, Dr. Mustafa?
So we have to ask whether the stool is mixed with blood or does the bleeding pass after you have passed your stool?
Oh, okay, good. Anyone else? Yes, Dr. Gibran?
I will ask the patient
Streak of
if the patient, if this pain is just, if this pain is just holding the patient to pass to open his bowels. If this pain is holding the patient to open his bowels.
Okay, okay, good, good. Anyone else want to add anything?
Sir,
Okay,
streaking of defecation, like it's a means the defecation is not of the normal size. It is a streak like. I think that is also
good,
seen in the.
good, excellent, excellent, excellent. Okay, Doctor, yes, Dr. Electron. We don't have neutron or proton here. Yes,
Yes, sir. I will ask the patient if the pain starts during defecation or it is before and after defecation too. Like if he feels pain when he is defecating, it means there is definitely a fissure
okay. Where is the pain? In the mouth?
in the anal area, like in the
That
anal
is the
mouth area.
question. No one is mentioning that. That is the
Yes.
most important thing, that where is the pain? So you have to mention is where, not about, you will not directly ask, it is a painful bleeding or painless bleeding. Obviously not. You will ask, when you pass the stool or blood, is there any pain in the back passage? So this is the only thing that is associated with anal fissure. You know, I included this one um, because many of the candidates were confused about this question, that what to ask. They ask only about the pain. Pain, remember, when you are passing the stool and pain is in the tummy, so what is it? You are passing the stool and pain it is in the tummy. What is it? Anyone?
Acute gastroenteritis.
Oh, okay. Or
Diverticular.
okay. Yes, but not specific. There is a specific thing there with that. And after that application, that yes, excellent, Dr. Jia. Yes, it is IBS. So you have to be specific. Where is the pain? So we, when we come up from the exam, we say that I have done excellent. I don't know where I failed. Here we, when we don't differentiate the things, they know each and everything. They are very, very specific. The examiners are very, very professional and very much supporting. So if you include only one thing, when you defecate, is there pain in any, in the anal area? In the peri or the back passage? Simple, back passage. That's one. And for the if there is no pain, there is no anal fissure. Is there no pain in the back passage? And if it is the pain in the back passage, then it means it may not be hemorrhoids, because hemorrhoids are usually painless, but sometimes hemorrhoids are associated. Patient is having two things, hemorrhoids as well as the anal fissure. So it is sometime, but not always. But if there is no pain, no anal fissure. Only in chronic anal fissure it comes. But it's not the subject of your study, obviously. You have just to include this question. Next, for the hemorrhoids, the question will be anything coming out of your back passage. Only one question. That's all. And it will also exclude the other differential, which is that bowel coming out of the back passage.
Rectal prolapse.
Yes, excellent. Rectal prolapse. Rectal prolapse. So all the differentials will be included, just, and it should not take more than 2 minutes. So why I'm taking just categorizing these, because you have to complete your history in 6 minutes. So your differences should not be more than 2 minutes. 2 minutes, 1.5 minute for the Socrates, and 0.5 minute for the your introduction. So almost 4 minutes are done. Now, after we are left with 2 minutes, these 2 minutes are for the next questions. And in your Bazid notes, remember, I have said it in the previous lecture, in the introductory lecture, that for the history taking skill, the book recommended is Bazid notes. I am writing my own uh, book, but that obviously will take time. We are trying to write our own book for the, because there are some things which are to be improved in Bazid notes. But it is a very, very excellent book, and we owe to him. And so in Bazid notes, eyes, what do you mean by eyes? Anyone? What do you mean by eyes? Yes, doctor. Yes,
Yes,
yes.
yes, sir. ICE means ideas, concerns, and expectations of the patient.
Expectation. So
Yes.
after completing your differential diagnosis, you will ask about the eyes. You will not uh, keep it at the end. Why? Because eyes contains your marks. If you have not asked about eyes, your marks will be deducted. So change it in your Bazid notes. Change it. Eyes will be after your differential diagnosis, so that your eyes is done. So you will ask the patient, what do you think the cause is? So simple. What do you think the cause is? What are you most concerned about? And what are you expecting from us to do you for you? So these three questions, quick three questions. So these three questions. Next, eyes. Sometime the examiner asks you only one thing. What is the patient most concerned about? They ask about only about this thing. What is the patient most concerned about? So that you should know that this is I have asked, and it contains separately 1.5 marks eyes, 0.5 marks for each question. Okay, after eyes, now you have to ask about the personal or the GP history or the family history, which is again very important. Okay, so now remember, before asking the patient about the personal history, you have again take the consent. You cannot enter into the patient's privacy before taking particular consent. So you have to ask, okay, Mr. Alex, would you mind if I ask you some personal questions for your own problems or related to your own problems? If you have not asked, you lack your communication skills. Right? Okay. So this is very important. Second consent is very important. Okay. So you will ask the patient, would you mind if I ask you some personal questions? So you know you're asking some personal questions. What are those personal questions? You know, all of you, that number one is about smoking, then about alcohol, then about if the patient is have been to GP, then if the patient is having some is living alone or with the family. So what question you will ask in the smoking? How would you ask this question? Dr. Sonia, how would you ask this question? Anyone, how would you ask the question for smoking?
Sir, number of cigarettes
No,
you
just
use
ask
per
me.
day.
Just ask me the question about
So
smoking.
tell me, do you smoke?
Yes,
So how many cigarette do you smoke per day
about 20.
and per year?
Sorry,
Per year, in a year, how many cigarettes do you smoke?
in a year I don't know, but usually I take 20, 25 a day.
Sir, it would be how long have you been smoking?
Yes, how long? Yes.
Yes, it is. How long have you? So, number one, that is why I asked to repeat the question, because I just wanted to know that how you people ask the question. See, thing is, okay, for example, like I have to ask about smoking. Any smoking? Not do you smoke or how have you been smoking? No, any smoking? No, or yes, yes. How many cigarettes per day? 20. How many years? 20 years. Okay, done. And next, fourth question. Have you ever thought of quitting? Have you ever thought of stopping the smoking or quitting the smoking? Right? So these are four questions related to smoking. So you have to ask, because uh, smoking causes not only one disease, lot of diseases. So smoking, four questions. Alcohol, again, any alcohol? Yes. How many units or packs per week? Not per day. These are per week. Okay. For example, now there is different guidelines say different. So some say that, for example, you ask the patient how many units or how many packs per week. You ask the patient. Patient says that it is 20. So what is the upper limit of the alcohol per week? Upper, uh, you can say that safe limit, upper safe limit for the alcohol. Anyone?
14 to 18 minutes per week.
Yes, good. It is 14. Previously it was 18, now it is 14. And previously it was 18 for the male and 14 for the female. Now it is all 14. So for the, if no, no, I'm again, if the patient is taking more than 14 units per week, then you have to ask about quitting. Or if the alcohol is the maybe the cause of the symptom. For example, the patient is of pancreatitis and the patient says that he's taking alcohol. Alcohol may be a cause of pancreatitis. So now you have to ask the patient if have the patient thought of any quitting. No, you have to ask. Otherwise, if the patient is just social drinker, because most of the patients will be social drinker. So if the patient is social drinker, you have not to ask about quitting, right? Okay. And then obviously about the family history. Family history in the family. How would you take family history, by the way? What question you will include? Anyone? Anyone? If you have to take the family history is important. You must take. What question you will include? Yes, Dr. Mustafa.
So has any of your blood relatives got a
Similar
similar
problem.
problems?
Good. Excellent. Number one, similar problem. For example, if the patient is having IBD, it will be similar problem. But if you are suspecting that patient is having some carcinoma, symptoms related to carcinoma, and for example, it is going towards esophageal carcinoma, and it is going towards the lymphoma of the tonsils, recent topic, recent history taking, and or it is related to colorectal carcinoma, then you can include that particular thing. For example, you can ask if the patient is having your bowel cancer or any of the relevant relative. For the bowel cancer, you can ask directly about the this tonsil cancer. If you are suspecting from the history that it is going towards some particular disease. Otherwise, it is a very good question that does you have, for example, if it is back pain radiating to the leg, you consider that it's not going to be some carcinoma. Then simple question: does any one of your family member having similar problem? Okay. And what about the past history, past medical history, and past surgery? Past surgical history is straightforward. Do you have any operation or surgery in the past? So it is very straightforward. But for the past medical history, two questions you can include. Number one, are you taking any regular medication from your GP? It's a good question. Are you taking any regular medication from your GP? And second thing, to include the important diseases. What are those important diseases? Hypertension, high blood pressure, number one. Number two, diabetes. Most of the patients here don't understand high blood sugar. They know diabetes. So diabetes is usually a layman term here. But if you are taking the exam in Pakistan, then you can ask the high blood sugar levels. So diabetes, hypertension, and then hypertension, high blood pressure, diabetes, asthma, tuberculosis, COPD, heart problem. So these are 4 to 5 things which must be included in your past medical history. Then is your drug allergy history. Never. Yes,
Sir, how?
please. Dr. Veer, can we could
Sir,
take the question at the end. Can you please hold it?
okay,
Sure.
sure.
Thank you so much. At the end, there will be question answer session one by one. Sure. So drug allergy history, if you skip it, the drug allergy history, because the examiner will not be allowed to kill you. Otherwise, if he is allowed to kill you, he will kill you. Remember, never skip this drug allergy history. Never skip that. Drug allergy history. Okay. And then the systemic history. Systemic history should be included at the end. Systemic history must be included at the end. Why? Because just a second, please hold it. Just a second. Yes. So systemic history, 5 systems, 5 questions, not more than that. So start from the head, headache, nausea, fits, vomiting. Headache, simple question. Any headache, nausea, vomiting, fits. For the chest and heart, it is simple. Shortness of breath, chest pain, cough. For the abdomen, simple question. Diarrhea, vomiting, abdominal pain, diarrhea, vomiting, constipation, abdominal pain, and yellowness of eyes. Yellowness of eyes. Any joint pain, any problem with your urine. Only 5 questions. 5 systems, 5 questions. So this is the layout for taking the history. Now, next important thing is presentation. Presentation should be for 0.5. Now, your 6 minutes will be completed. You have to pay thanks to the patient. Now, there are 2 scenarios. One scenario is that you have completed the history before time. So, if you have completed the history before time, the examiner will ask you, have you completed your history? Yes. You can ask any other question if you have time, because they will not start your presentation before 6 minutes. So they will allow you to ask the questions. They will allow you that if you have any question, you can ask. Number 2 scenario is you have not completed the history. So most of the time, you have not completed the history. What to do now? So simple. Just pay thanks to the patient. Thank you so much. So this is very important. Again, this is again very important. Pay thanks to the patient. Thank you so much. We will be back to you after consulting with our consultant. Thank you so much. We will be back to you after consulting with our consultant. Why? You are not authorized to take any decision. You are not authorized to take any decision. So you will say that, thank you so much. We will be back to you after consulting with my consultant. Guys, I have repeated it 3 times. So I hope you won't ignore it. It's not from me. I have passed my exam. So it is for you. So it's very important. Next, your presentation. And that presentation will be should not exceed 30 seconds. Presentation should not exceed 30 seconds. You can now look at your paper. You can even present your whole presentation, your whole case while looking at the paper, and just like Simon, you no look shot, no look to the patient, to the examiner. Just look at your paper if you want to. If you can memorize, otherwise, and you can speak well without looking at the paper, then it's good. Otherwise, there's no harm in looking at the paper. So what should be included in the presentation? While you have seen that we because our English is not usually that good, and we struggle in making sentences, so just include the positive things. For example, if I have to tell you, I will say this 70-year-old male. Age is somehow important. If you don't remember, it is not a negative thing. So if you mention, it is positive. 70-year-old male. Otherwise, you can say that middle age, young, old. If it is more than 70, old. If it is middle age, you can say middle age man presented with. Now you can include medical terms. In history taking, no medical term, all layman language. In presentation, medical terms. This 70-year-old male presented with PR bleeding for last 2 months. Fresh, increasing, couple of spoons a day, associated with weight loss, anorexia, alternating bowel habits. Family history is positive for colorectal carcinoma. Patient is chronic smoker. That's all. Only positive things. It is not your consultancy exam where you have to include important negative things. Only include positive things. And then you can say at the end, rest of the history is insignificant. If the patient is having some significant, for example, past history, past medical history, or patient is having some other symptom, you can include. Otherwise, only positive thing. And not say that patient is stating like that. When we say that patient is telling like I am having sometime diarrhea, sometime as this blood is coming for it means I'm not sure what it is. But when I say that patient is having alternating bowel habits, it means I have concluded from the patient symptom, patient statement, that it is alternating bowel habits. Similarly, if the patient says, no, I have some mucus discharge, and I say that patient is saying, I see he has coming something else with that, it means that I'm not sure. So you will say that, we will say that simple, that we will keep our presentation so simple. So next, after the presentation, they will ask you, okay, how will you proceed? So what we normally do after history? Anyone? What we normally do after history? Yes. Yes, Dr. Mustafa, Dr. Sadia, yes.
Examination.
Yes. So after the history, patient will he will not say that what investigation you will do. He will ask you that how would you proceed. So you would say, for no, this is very important thing. One important point I want to tell you. If you have not completed your history, if you have not completed, and some questions were not asked due to limitation of time, in presentation, you must tell the examiner that I want to tell these questions. This is important. You must tell the examiner. For example, you have not asked, you could not ask family history, or you are presenting the case and then you recalled that, oh, I have not asked about the appetite of the patient or not asked about the weight loss of the patient. So present your case very calm and then say, if time, I could not ask these questions due to time limitation. So simple. Examiners are very good, excellent examiners. They will accept it as positive. So it happens. Obviously, there is an exam pressure, a lot of pressure, and it happens that we sometimes miss some questions. So if you miss some questions, just mention in the history, in the examination, in the skills part, even in the knowledge part. If something is missing, tell at the end. So you must include in the presentation. So the examiner will ask you, how would you proceed? So how would you proceed? You will say, I would do examination. For every system, there is different examination. So what I say, I would do detailed examination, including GPE, general physical examination, abdominal examination, digital rectal examination, and relevant examination for the abdomen. Just telling you for the abdomen. Okay. So these 4 examinations will be included in this. And then after examination, what you will do? Anyone? Yes, Dr. Shafiq. Yes, Dr. Shafiq, what you will do after examination? No, not
I will go for the investigation
no,
first,
no,
some baseline in.
no, you will not go for
Okay,
the investigation. No.
okay, sorry.
Yes, Dr. Jia. Good. Discuss with my consultant. Excellent. I will escalate with my consultant. So you will say, I will do detailed examination, including GPE, abdominal examination, detailed examination, and relevant examination, and escalate with my consultant. Okay, then he will be happy. Okay, next, after that, he will ask you what investigation you will do. So remember, I have already told in my all previous lectures, in all my classes, that categorize your investigation, just like Dr. Vakas did, into 3 categories for these cases. Into 3 categories. Number 1, general investigations. Number 2, diagnostic investigations. And number 3, if you are suspecting that there is carcinoma, staging workup. You have to tell to the examiner for that I will do investigation like this. Remember, now in the exam there are 4 marks, 4 marks for that how much you understand the case. Only this thing. 4 marks for every station. So these 4 marks are subjective and you have to earn that. And where we lose these 4 marks, we lose in our presentation, we lose in our answering the questions, because we are answering the things but not in a good manner. So remember, this technique is it is not my recommendations, it is Royal College recommendations, that you have to answer like that. So you have to answer like that, that you are number one, examination, then escalate with the consultant, then if they asked you about the investigation, general investigations, number two, diagnostic investigations, and staging workup. So you will include like this. So in the, they will not ask you about the general investigation, because they know that general investigation, if they ask you general investigation, you know, you should know this is FBC, urea and electrolyte, CRP, and liver function test, all these investigations, you know, they will ask you, and that will include the marks about the specific investigations. And you should know that which specific investigation is important. Remember, in these, either it is IBD, either it is colorectal carcinoma. Single most important investigation for both of these is colonoscopy. Okay. Now, if they ask you what test you will do at your clinic, anyone, which test you will do at your clinic, or which investigation?
Sir, we will start from DRE.
DRE is examination. DRE and proctoscopy. Which investigation you can do at your clinic? That is sigmoidoscopy.
Flexible sigmoidoscopy.
Yes, excellent. Dr. Shafiq, flexible sigmoidoscopy. So you can do flexible sigmoidoscopy at your clinic. So digital rectal examination and colonoscopy and proctoscopy, that is part of examination. And flexible sigmoidoscopy, that is part of. Okay. So in the specific investigation, there will be, number one, colonoscopy. At the clinic, there will be flexible sigmoidoscopy, and other specific investigation is, if there is colorectal carcinoma, there will be CEA, carcino embryonic antigen. All of you know that. No need to repeat it. Question asked is, why CEA? So answer is, anyone? Why CEA? Don't say that it is a diagnostic.
It is more sensitive.
No. Don't say it is.
Prognostic. It is more like of prognostic, not for the diagnosis.
Yeah. For Dr. Jia, and you are right, Dr. Shafiq. Prognostic, I will say that to get baseline levels for recurrence. Okay? To get baseline levels for recurrence. So I'm quoting you the questions as well as the answers. I'm not leaking the questions. So it is like baseline levels for to follow up for the recurrence.
Say surveillance.
Surveillance, right? But usually for surveillance is, this is for surveillance we do CEA, but most specific is colonoscopy. For surveillance is colonoscopy, not CEA. More specific, but we do CEA for the recurrence, obviously. But if CA level is going up, we will do colonoscopy just for. Okay. Next question is, what diagnostic and no staging workup? So staging workup, you know. And staging workup, you know, CT scan, CT tap, and if there's rectal carcinoma, then we go for MRI. And they ask you CT scan with contrast or without contrast.
With contrast.
Yes, with with the oral and
Rectal and IV.
rota IV contrast. Good. Okay. Okay. And for the, if this is IBD, then you will go for call protectin. Number one, call protectin levels as well. And CRP and ESR levels. And then they ask you about the treatment options. They don't ask you in these 2.5 minutes, what is the treatment? They ask you what are the treatment options. You should know the treatment options. Okay. So you should know that in surgery, number one is surgery. Number two is chemotherapy. Number three is radiotherapy for colorectal carcinoma. If they ask you in the what are option in surgery, you can say that if it is right-sided, right hemicolectomy. If it is left-sided, the options are, you know, APR and proctocolectomy. So, but they don't go into details, such details. They just wanted to listen you that surgery, radiotherapy, and chemotherapy. Okay. And if it is IBD, then what is the first option? Yes. If it is IBD, first option is
Anti-inflammatory.
Medical treatment is the first option.
medical disease. Medical treatment is the first option. Surgery is the last resort. So mention it, medical or conservative first, and then surgery, right? So in the medical, what is the medical treatment? Steroids, number one, because they are asking these things nowadays. Steroids and anyone?
Sulfasalazine, salicylic acid.
Yes. In which category these come? Sulfasalazine and these things. Anyone? Immunosuppressants. Good. So you will include, you will say that steroids and immunosuppressants are immunomodulators. Nowadays, a better word uses immunomodulators. So you will include that immunomodulators, steroids, 5-aminosilicic acid medications, and biological therapies. So you will include these things. And then you will say that I will go for the surgery. And if it is usually Crohn disease, we usually go for right hemicolectomy. And for the ulcerative colitis, usually we have to go for, you know, protocolectomy. So any question now? please, one by one. Yes, any question, please?
Sir, we asked in person history about have you ever thought about quitting smoking or quitting alcohol?
Yes.
So, what was the significance of it, and how will we present this to the examiner in presentation?
Ah, yes, this is important. So if the patient is is smoking and not quitting now, right? So what will be the effect of impact of smoking on surgery, Dr. Wahid?
Sir, it will result in delay a healing.
Delayed wound healing. Delayed wound
Yes,
healing, right?
yes,
So
yes, sir.
this is important for that. Okay.
Okay, sir.
Okay. So that is why it is important. Secondly, in some, for example, bladder carcinoma, lung carcinoma, smoking is important. Even for the bowel carcinoma, it is important. Okay.
Uh, yes, sir. And in presentation, we will tell our examiner that he is a smoker and is not planning to quit smoking.
Yes,
Is it correct?
exactly. Exactly.
Thank you, sir.
Yes. Next question, please. Someone share if the patient is yes about quitting smoking, what will be she says yes, no, but oh, okay. No, we will not give any decisive reaction or any exclamatory mark. It's okay. If the patient says yes, okay, good. Okay. If the patient says no, if the patient says this, I am trying but I'm not able to, then we have to good. Then we have if the patient says that yes, I'm trying, but I'm not able to. Then we have, okay, we are here to help you because they are separate smoking cessation clinics. So you say that we are here to help you for this purpose. Okay. Otherwise, patient says yes or no, nothing. Nothing to do with that. Dr. Zuhaib said before asking patient about quitting smoking, better to ask patient what motivates him to keep. No, 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 no. No, Dr. Zuhaib, don't give to in these details. What motivates to keep smoking? No, 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 no. This is like being very personal. Dr. Jia, I have said that if the patient says no, that's okay. If the patient says yes, then we have to ask how many cigarettes per day, for how long, and you know how to calculate pack year history. How to calculate pack year history. Anyone? Yes, Dr. Mustafa?
So it depends on the number of cigarettes he is having per day. So for instance, one pack consists of 20 cigarettes, and if he
Mhm.
is having 20 smokes per day, so that means one pack, matlab, one pack per day. So 12 pack years, I guess.
Mhm, mhm.
And
Pack,
no, sorry.
pack year
So and
history.
the number of years he has been smoking. So for
Yes.
instance, he has been
For
smoking for
example,
20 years, so
good,
20 pack
good,
years.
good, good. If the patient is taking one pack per day and taking for 12 years, so total history 12 pack year history. If the patient is having half pack, 10 cigarettes per day, and for the last 20 years, so it will be 10 pack year history because half pack per day, right? So it will be 10 pack year history. So 20 pack and 10 is it is just like that. Okay, anyone? Any other question?
Sir, in past history, after asking, are you taking any regular medicine? How will we inquire about TB, hypertension, ischemic heart disease? Will we include this in a single sentence or will we ask him separately that Are
Okay,
you
I asked
having
you. Thank you so much, Dr. Wahid. I asked you the question. Okay, okay, Mr. Wahid, do you have any TB,
no,
tuberculosis, asthma,
no, no,
COPD,
no,
hair disease?
no.
No, good. That's all.
Okay,
So quick.
good. Thank you, sir.
Anything else? For history taking, I told already it is Bazir notes. It is Bazir notes. So not do any not do history from Sala notes or from Turkey notes. Do history from Bazir notes. If there is some news station, you can do that from that from Sala notes. I am first writing these communication skill stations and then knowledge stations. So I hope that till the end of this year, inshallah, we will able to complete this communication skills part. Okay, if there is no question right now, so we can conclude our session today. I hope it was helpful for all of you. And if you have any question, you can ask later on for the in the group. We are here to help you. Don't worry. Anytime. Thank you so much, guys, for your participation.